If oh, there, okay, I'd love to turn it over to our executive director, Eric Weaver, who can do a welcome and intro, and then we can kick off the formal conversation with y'all.
Well, thank you, Daniel, and thank you all for taking time out of away from your families this evening to really focus on such an important issue. As you all know, this is Black Maternal Health Week, and this is really an opportunity for us to galvanize around this important issue of health equity. And it's pretty alarming and horrific to think about the poor maternal health outcomes in the African American population in our country. And I was shocked when I saw the documentary, and Dr. Neil Shaw, who was featured prominently in the documentary, mentioned that this is an issue that hasn't even been publicized in the media since, I mean, until like 2018. So and obviously the origins of some of these systemic issues go back well into the era of slavery. So for me, as uh, someone really learning about this issue, and I, as executive director for the Institute for Advancing Health Value, myself, Daniel, and us on this team, we're really committed to providing this ecosystem for sharing and collaboration and peer learning. And we have an opportunity for anyone that's in a healthcare organization to join and be a part of really an important movement in terms of health equity and population health. Um, and yeah, definitely check us out online. And there's a free membership for provider orgs. But I wanted to, I guess, kick off a conversation. And I felt like this film did a really good job of turning pain into power. I mean, it was really inspiring. And one of the quotes that Dr. Shaw, said in the documentary was, the well-being of moms is a bellwether for society in general, and every injustice in society shows up in maternal health and maternal health outcomes. And I think that would be kind of a good frame to kind of start our conversation today. I welcome anyone to raise their hand, and feel free to introduce yourself and provide your perspective. Any insights you gleaned from the documentary. We definitely wanted this to be a very collegial and collaborative type of discussion. But just as a moderator, Daniel and I are going to kind of take turns kind of guiding the conversation. So just to make it easy on us, just feel free to raise your hand. There's a little button on the bottom of the screen that'll help you do that. And I'll wait for the first person that wants to raise their hand and make a comment.
I just have one comment. Thank you everyone for being here, but if you would like to turn on your camera, please feel free to do so as well during this time. And also, if you wanted to keep checking the chat, I'll be sending links in there as people are referencing them.
Well, Dr. Walker, I'll volunteer you to get this party started. You mentioned you have some background, obviously, in OBGYN. You're now, one of the leading innovators in value-based advanced primary care delivery. I'd really love to get your perspective on this important issue. And, one of the things I think that I wanted to ask you specifically was just around this concept of culturally competent care, because the research shows that outcomes are better when care is delivered by people within an interdisciplinary care team that reflect the attributes and the characteristics of the patients being served. And I wanted to just kind of get your take on the confluence of where that might be an opportunity through workforce, maybe to ameliorate some of the poor outcomes that we see. And but I'll just kind of let you kind of provide some perspective on that. I just thought that would be a good place to start.
Thank you, Eric, Daniel, and Shemaine. I really appreciate it. One of the things that might be shocking to a lot of people in healthcare is that being pregnant and having and delivering a baby is not a disease. We treat it like a disease. Um, but when you take it from the realm of the terminologies, the active management of delivery, uh, and you take it from that realm and you put it back in the hands of those who can support a mother through a natural process, you have better outcomes. And as the team from the Institute knows, that my biggest thrust nowadays is, we started out in the living room in healthcare. We moved it to the examining room, and then now it's in the hands of the boardroom. And what we have to do is get it back to where the living room is preeminent and predominant in everything that we do in healthcare. And what that basically means is it really, healthcare starts in the community. And for the most part, with the exception of telemedicine and what that brings and some of the advantages, healthcare is local. And that means that you have to have it in the community, people who are in the community, who know the mothers, know the community, know the situations and the circumstances. All of those things matter. In today's world, healthcare world, we talk about the social determinants of health, but even there, we talk about the social determinants of health on a high level. We talk about things such as transportation, address, education. Well, none of those things really can be changed within a short period of time, and most of them require policy. But if you take the moms that we're talking about, if you take the seniors that we're talking about, if you take those with chronic diseases that we're talking about, all those things happen in the community on a daily basis, and they can't wait. And so, as we're talking about maternal health, it comes back to the same mindset, that it's about the living room and what we can bring to that environment for every mother, every family, every situation and circumstance. And it's about the community and what the overall healthcare community can bring to that local community.
Dr. Walker, I love what you're saying there, and it's such a critical thing. And I was just blown away, as obviously not, I'm a father of three kids and traditional hospital births for each one of them. A couple minor complications that I was grateful didn't get any worse. And I watch a video like this and just the increased awareness that I received, I'm so grateful for, and just um, blown away and hurt by the suffering that is so needless and that should be prevented. And I hear about what you say, Dr. Walker, and it makes me think about the birthing centers and doulas and the opportunities for community to help, and that it doesn't necessarily need to be a medical industrial complex solution. And I just, part of this is so much of I think the movement to make the improvement starts with the acknowledgement and the awareness, and obviously I'm early into this process of understanding it and being aware compared to many of you who've probably lived through a lot of it. Having said that, I'd like, Michelle, I know you've had your hand up for a minute or two. I'd love to get your response and share your insights if you would like, and then if anybody else, you can build off of what Dr. Walker has said, or Michelle, as we continue.
Thank you. Thank you so much. And I do want to say thank you to the Institute for actually affording us this opportunity, because this was very eye-opening. So earlier on, I was introducing myself, and I'm in academia, so I have not been in patient care for quite some time. And what I was taken aback by, going along the same lines with the cultural competency, is I understand that we moved to more evidence-based practices, but I had no idea that we are using algorithms that are probably already biased against races when we look at, specifically focusing on some of the social determinants of health and other things to start with. So it makes me wonder if sometimes some of the practices that we've put in place, it makes me wonder, when did we put those in place? Did we have these kind of considerations before we put like algorithms where people are literally, using these to make their decisions because maybe they don't have, like the Harvard students were saying, we don't have lived experience, so all we can do is be, actively seeking information. But are the tools that we have been developing kind of hurting our situation a little bit more? And so I'm just curious, to what the group thinks about even the tools that we're using for that.
Let's go to LaDana and Bridget. If you guys have responses to Michelle, feel free to add those, and if not, then we can circle back.
So for me personally, I come from a background of maternal health. I've been an OB nurse for 16 years now. And when you think about algorithms of any nature, they typically are naturally biased. But from a lot of what I look at is actually from a nursing standpoint versus a medicine standpoint. And a lot of the evidence-based practice, it is not geared towards what has been researched on minority individuals. So it may be evidence based on, like, for example, not even maternity health related. When you look at certain medications for high risk, for like high blood pressure, they've been shown not to work in African American individuals. But guess what's the first one that's ordered? So when a lot of times you look at evidence based research and evidence based practice, it's not necessarily geared towards. It's not geared towards any minority or a specialized population. So I do agree that we may need to look from a standpoint of that. But from my own personal practice and just being 100% honest, one thing I've always been clear on is, I am the nurse. I am there to advocate for the patient, regardless of what circumstances they have going on. I'm there for them. I am their advocate. But when you think about maternity health, it really is based on their physician. It is based on what that physician thinks. Do they agree in a holistic methods? Do they agree with, doing vaginal deliveries after C-section? Do they agree with natural methods or I'm going on vacation next week, so I need you to deliver by Friday. So there's various things that kind of go into play when it comes to a laboring mother, especially a high risk mother that is delivering a baby. And so you do see more C-sections. So when you look at the US rates, we have the highest cesarean section rate amongst any other country. And that's because we're basing our maternal health on medicine, not necessarily other methods, which would be vaginal. And so then you end up with post-op issues. You end up with the pulmonary embolism and the risk of bleeding and everything else because it's still a surgery. And it should be still treated as a surgery either way. So that's just kind of my 2 cents based on my actual practice.
Thank you, LaDana. Bridget and then Rick, we can have you join in.
Yes, good evening, and thank you for this opportunity. And I apologize, I've been trying to get my camera working, but for some reason it's not clicking in. I work at Blue Cross Blue Shield of Michigan, and I lead our inclusion and diversity area as well as our Office of Health and Healthcare Disparities. And viewing documentaries like this really have a huge impact on our employee. In fact, actually next Tuesday, we'll be viewing this for about 800 employees that are registered to attend the session and actually hear from those who are part of the documentary. And what I've learned when we have sessions like this is that it truly is eye-opening. It brings an awareness that takes us from just focusing on the data and begin to focus on real people. When you talk about culturally competent care, it is that opportunity to truly move beyond seeing this person as another patient or this person as a Black patient where unconscious bias comes in, but really that opportunity to begin to connect with that person and build trust. What I've learned is that in many instances, the people who are developing the policies that we have, the processes and the evidence-based care, they're not really thinking about the people, and they don't hear and understand those stories. And once you start hearing those stories, you begin to think about the policies, the practices, the processes in such a big different way. And in the documentary, you just hear all the different things about unconscious bias and how that shows up. How the question, the number of questions about, are you on? Does she take drugs? Do they ask everyone that? Probably not. Um, but sometimes, again, it's the stereotypes, it's the assumptions that come into play. So again, these opportunities to create that awareness helps to build that cultural competency and helps to kind of move people out of that place where they're just providing care without really thinking about it, thinking about the people, thinking about their stories, building that trust and making that connection. Thank you.
Rick, I believe you have your hand raised as well, if you'd like to make a comment.
Yes, good evening. Can you hear me okay?
Yes.
So I'm a family physician by training here in South Carolina, and I was one of the founding leaders for the South Carolina Birth Outcomes Initiative. I am now fortunately retired from the statewide work, and a lot of that was around trying to improve birth outcomes in our state and recognizing the very large racial and rural equity gaps, both in infant and maternal outcomes. But one of the things I wanted to comment on based on what I've already heard is, to me, the real challenge on the medical professional, the clinical professional side, is most clinicians still are much more comfortable with clinical solutions. And so when you look at things like our work with a lot of other states on the AIM program, it's much easier to get clinicians focused on establishing a hemorrhage protocol in the hospital setting, or thromboembolic prevention, in the hospital, than working on measures that would hopefully start as early in the prenatal process as possible for those pregnant women with existing hypertension, diabetes, who are going to be at risk, or the follow-up in the postpartum period. When you match that still discomfort level of the clinical community and looking at non-clinical solutions, and understanding that often they may be the bigger driver of poor outcomes than indirectly than the clinical outcomes, and the implicit bias. When you put those two together, even those clinicians who say, I want to do something differently, just lack the perspective and the understanding of how they accomplish that. So in South Carolina, I will say that our community health centers, the ones who are actively involved in maternal child health, are the ones that do the best job. If you look at their maternal outcomes and infant outcomes, they're better than the private practitioners and even the OB practices in our larger centers. And I think that's because they take a more holistic approach. They already have experience with cultural humility and understanding. They are more likely to incorporate community health workers, behavioral health specialists. They also, in the postpartum period, are the one entities in our state that actually can do a mom-baby dyad as far as care. Because some of these women that get in trouble in the postpartum period, they have to make a totally unacceptable decision upon, do I take time off from work to take my baby to the doctor, or for myself to go in the doctor? And so they're not even getting their blood pressure checked or their blood sugar checked, and they may be getting in trouble. So yes, the bias comes into play, but we've also created a system that is not responsive in the way that it needs to be for both care that needs to occur, especially in that initial postpartum period, as well as addressing the social and environmental economic factors. I will say, as an additional side note, we just got our report for the most recent year on infant and maternal morbidity and mortality. Didn't look good. Obviously, the pandemic didn't help anything on this front. But the number one cause of maternal morbidity and mortality was cardiomyopathy. It wasn't hemorrhage. Those are important issues, but realizing that you've got, which is more predominant in Black women, that there is pre-existing conditions that could be better identified even in the prenatal period and better managed, as well as in the postpartum period. That's a different approach to care that a lot of practitioners are comfortable with yet. Thanks.
Well, thank you, Rick. And it's a great point. A lot of great insights there. And just on the what I remember in discussing this issue with Dr. Shaw when we had him on a recent podcast, he talked about how a lot of these Black moms aren't even dying of the medical condition like what's stated on their death certificate. I mean, he framed it as like oftentimes this death is caused by failure of communication. There's also, to what you said, the pre-existing conditions, and you go upstream, you look at a lot of the social determinants of health, the barriers that we impose on society, institutions, policies, how we create urban planning of districts, and in ways that we create these obstructions in a person living to their fullest potential. And it's just truly systemic. um I wanted to, yeah, that was one insight that I had. I did want to go to the next question. Looks like Dr. Smith, you have some comments. We'd love to hear your perspective on this as well.
Yes, thank you so much. And thank you for allowing this opportunity. I too am a family physician of 32 years in a community in North Carolina. And I've had the opportunity of certainly delivering babies, just as Dr. Foster sounds like he may have delivered some in his experience as well. But I will tell you, the reason why I'm in my community is because the women that we care for are Lumbee Indian women, a Native American Indian. We also have African American. We also have Latinx. And I tell you, one of the things that we see that's crossing over all women that come into our path is that of social drivers of health, which we certainly, you've hit on quite a bit of it. And it's a concern because we know it's more than just a biological issue. And I appreciate the death certificates noting that of cardiomyopathy. But why? Why is the cardiomyopathy not treated or identified or cared for properly as it may be cared for in others? And so I think we still have more work to do. I think all of us can be advocates for each other, for the women that we come into contact with, for the dads who are still taking care of the raising the families. So there's much more for each of us to do in the communities. And I appreciate the film bringing out such an emotional component. The last thing that I want to mention, in our community, we're very well familiar with the use of doulas and how they have had a major impact on helping a woman go through pregnancy and delivery, and working with the midwives and the physicians working as a team with the doulas, with midwives, with the family, because it's going to be a collaborative effort. It's not going to be that of the held in the lap of the hospital or the physicians. It is going to be a true team collaborative effort if we're going to make a difference, and making sure that we recognize the cultural benefits that ladies have from generations that perhaps we don't allow to stand out in the hospital setting. So thank you so much for everyone who's participated and being on the call. But I ask you, become part of a team, become part of a collaborative. No one's profession, no one area. It will be a collaborative effort, and all of us raising up this issue.
Dr. Smith, thank you for that comment, and I can't agree with you more. It needs to be a collective effort, and I'd love to see the participation that we've got here of so many people interested and wanting to take additional steps on advancing maternal mortality and the care that women receive giving birth. And I just want to make an important acknowledgement. I know the meeting invite said we were going to end at the bottom of the hour. I think it was a little bit of a mistake on my end that I intended for the meeting to go longer than 30 minutes or the discussion. So anybody who wants to stay, you're welcome. Feel free. We've got more hands up. We'll keep the discussion link open, so nobody needs to feel like they've got to jump off at the bottom of the hour. We've got two hands up, Cheryl and Jessica. We'd love to hear more from you. Just before I turn it over to you, I want to point also attention to the chat. Just make sure you're looking there. We've got some great comments from Sandra and Michelle, and I wish I could feel confident in pronouncing your name. Maybe you can tell us Amau Chechukwu. Give it a shot. I'd love to hear you say it, but thanks for the comments in the chat, you guys. Cheryl, let's start with you.
Well, hello everybody. Greetings from Detroit, Michigan. I have been a practicing obstetrician and gynecologist for the past 34 years, born, raised, and educated in Detroit. And I share some of Dr. Walker's concerns about being a practicing physician. But let me just first say, so I practiced OBGYN for 34 years up until July 8th. And then 3 days later, I went over to Blue Cross Blue Shield. So I'm actually with Bridget Hurd, and I am just really grateful for the amazing work that she has actually done over at Blue Cross Blue Shield in Michigan for the past 5 years. Totally unaware of that, that Blue Cross was doing this, but now able to join with her and her work in maternal health. So that's a blessing. But my comments are several. We talk about, and we've discussed a lot of things here, which are all amazingly great. We talked about the AIM program that is from ACOG. Just a couple of things that I do. I actually am our American College of Obstetricians and Gynecologists representative to the American Medical Association. I serve here in Michigan on multiple committees and our Michigan Council for Maternal and Child Health, but our longstanding Michigan Mortality Surveillance Committee, in which we actually had just got legislation through about 5 years that maternal deaths have to be reported. And that's not the same all over the country. But anyway, the importance of reporting these maternal deaths is so that we can then make an impact on the ones. And in Michigan, in our state, and our data does show that hemorrhage and hypertension are the major causes of the preventable deaths in our state. But at any rate, just getting a little bit to what Dr. Walker was saying, and being a Black doctor and trying to take care of all patients, but Black patients in particular, one thing that we don't tend to talk about is what happens to us. And that's the racist manner in which both the physician is treated as well as the patient. And so if we don't, don't start discussing this, we can say that, yes, obviously it would be better if the and in a lot of instances it's good because we do understand from where our patients are coming from, but just the manner in which we're treated, no matter what I am. I mean, I can have on my scrubs. My dad is a retired doctor. I took my retired doctor daddy to the ER of the hospital I'm on staff at, and we were both treated like crap. And this was just a year ago, and my dad just died, more recently. But the manner in which the majority of Black patients are treated when they enter the healthcare system is something that we really have to get a handle on. And yes, we have our AIM bundles, but the AIM bundles are not implemented the same to all, to patients. I mean, I saw that in the health systems that I worked at. So, two different patients come in the same different room. One's Black, one's white. The Black patient, we know what to do. The bundles tell us what to do, but they don't get applied the same way. And then it's the manner in which our medical students are reared up, getting treated. I don't know if you heard about the recent thing that happened out in California where there was diversity and inclusion, and you had the school, their surgical department looked very diverse, and those Black students were getting like hate mail, and I'm not going to come to that hospital. And it's just the manner in which, we are mistreated, and it deals with the racism. And I think that we have to discuss it and just get to the bottom of it. And okay, so we do have our implicit bias courses, and our governor here in our state actually signed legislation that everyone who gets a license to practice anything that has to do with patient care will have to do the implicit bias course. However, you know, a lot of people are just trying to, oh, well, how can we get this done really quickly? But at least it's a start. But I just think that until we start to discuss the manner in which, you know, it was brought up, the reason why Felicia went to the tried to seek out a midwife is because, you know, because the, you know, she was like, well, the Serena Williams, who's like pretty famous, you know, can't get care. What's going to happen to me? And, you know, I actually saw this from a different point about being a practicing OBGYN here in the city of Detroit for 34 years. But then I'm a grandmother now. My daughter recently had a baby and my granddaughter is 10 months old. But just even going through that, I'm in the hospital with my daughter. She delivered out in LA. They moved back here now. But they didn't care. You know, the man, she was mistreated. She was hypertensive, supposed to be delivered before 39 weeks, based on some things. So she got good care up until the point where it was time for her to deliver. And then on the day that we were going in, a week beyond when she was supposed to deliver, she gets a call from the nurse and they're like, well, you know, you can't come in right now. We'll call you when you come in. And then she goes crying and sobbing and everything. And what kind of way is that for anyone to have to, you know, go into to a delivery? But all I'm saying is it doesn't matter who we are, what we are. If we're Black or brown, we are treated differently. And until we address that, then we're going to continue to have these. I was trained with midwives at Hutzel Hospital here in Detroit. So my training is a collaborative training. We work well together, but if your skin is Black, you just mistreated. And I just wanted to bring that, you know, if we don't start, you know, discussing what the root of it is, which is the racist treatment that we get, it's not going to ever get better. And thank you for listening.
Well, thank you for your important comments, Dr. Gibson Fountain. You know, just it's just overwhelming to think that we're at a point where we still have such deeply entrenched and systemic racism. And, you know, we've talked about how it's embedded in our algorithms. You know, there's implicit biases, you know, at the point of care. And then I even put a comment, you know, I was blown away by learning about, you know, Serena Williams and her story. And it just seems like there's in the current way that we deliver care, like no one of color is really immune to experiencing racism. And that's something that we, like, I think as a country and as a society have to elevate our consciousness to be actively anti-racist and think critically about you know, how we're really delivering care. And I think the data speaks for itself. You know, and this is such an important opportunity for us to have these powerful conversations and translate that into action. I did want to call on Shemaine, if you could provide your perspective as well, and then I'll let you call on the next question or comment. But Shemaine, I know you had your hand up earlier.
Yeah, of course. Thank you, Eric. So, hi everyone. My name is Shemaine. You probably got emails from me. And I work for the Institute for Advancing Health Values. So I'm really appreciative for everybody being here today. So with this documentary, I just wanted to bring up, just to Dr. Walker's point and also to Dr. Fountain's point, was that care is moving into the boardroom, which going on into that racist piece and into that collaboration piece, who's actually in those boardrooms, right? We want to make sure, which I haven't really seen, and I think that just listening to documentary and just, you know, having a public health background, that the doulas, the patient advocates, the nurses, the midwives, the breastfeeding consultants, the CNAs, right? They should all be in that boardroom too, because they are the ones that are actually doing that care. And me just listening to this conversation, I start to think, well, where's that collaboration piece at, right? Because we want the people that are actually doing the care to be in the room to say what care should be happening. And you also want a patient there, right? A patient that's went through this trauma. So that way they have that time to speak to those people who are making these decisions for all the patients. something else that I just wanted to say, and I think that that's one of the main things that I wanted to get to, is just why representation is so important, right? Representing those small pieces, right? People that normally aren't in the boardroom need to be in the boardroom because they are firsthand dealing with these patients. They are the ones that are treating them. They are the ones that are helping with the families. They are the ones that are dealing with the aftermath of it. So those are really the people that I think need to be in those rooms. Um, and just that this documentary, I am a Black woman. I can say I don't have kids. So I knew that some of this stuff did happen, but just this documentary really opened my eyes. It kind of made me scared to have kids because of all the things that could potentially happen. So that was really all that I wanted to say. Like I said, I'm very appreciative that everybody came here today and is in this discussion. I think Dr. Foster, you might be next.
I think there were some other folks before me, but let me just say quickly that as you can see on the screen, I'm an older white male, Southern white male, who's worked in the South Carolina health system for 48 years. And I have been through, and here's where my concern is, I have been through a range of implicit bias and cultural humility training, and it has helped me, but nothing to the level of the fact that I was fortunate enough about 12 years ago to go through a training program led by Dr. Marshall Gans up at Harvard around community organizing and using social movement methods for changing what happens at a community level, and then being embedded in a highly vulnerable community in Columbia, South Carolina, a very large African American population. It wasn't specific to birth outcomes. It was more focused. We ended up focusing on the huge problems with diabetes, so it indirectly did affect that group as well. It took that for me to gain the level of, I think, cultural humility and awareness that my commitment has been over the last 12 years, all built around health equity and in particular racial equity, and particularly around the maternal child population. And so what I worry about is, let's say we do this screening for every hospital board member in the country, and that will help. But if it's not followed up by someone sitting with those board members and those senior leaders, both clinical and administrative and government leaders, and saying, here's what we need to be actually doing, both on the policy front and programmatic front, I think we're going to be disappointed. So I applaud the fact of having these screenings and these discussions, but we've got to find a way to provide more experiential learning, even for senior leaders, so they understand that, for instance, when we presented to a lot of senior leaders in the state about the fact that Black women during pregnancy, even if they have a college degree, have worse outcomes than a white woman that didn't even graduate from high school. And that if you look at multi-generational African-American women in the United States, South Carolina, compared to first generation, the immediate response still is, for a lot of the clinical folks, oh, there must be some genetic difference. And they don't mean epigenetic differences based on microaggression and other things. And so if they don't have that perspective, while I think the screenings are important, we've got to find some other things we can match with that says, we would like for you to do this or that, as far as gaining more of a in-depth understanding of what it will take for us to really change the way we provide care and the way we address the factors that are causing these poor outcomes and these inequities. Thanks.
Dr. Foster, thank you for that contribution. If you've got a link, and if any others have links to experiential programs like that, we'd love to collect those resources and make those available to everyone. We've got a few people in line, so I'm going to list an order that we're going to follow, and I apologize if your comments were relevant to a more recent thing and the conversation wanders. Just bring us back to what's relevant to your thoughts. We're going to start with Jessica. We'll go to Vera. We'll go to Tiffany, and then Dr. Walker, and then Tanya. And if other hands pop up, then I'll try to keep those in line. So Jessica, why don't you kick us off?
Good evening, everyone. I am Jessica. I watched the Aftershock movie as a extra credit for a class. I am very emotional because I do have two young boys of my own. And I have, since taking my courses, I have been comparing the healthcare that I have gotten from my first son in 2018 to the healthcare that I received with my second son in 2021. And there are two totally different instances. The second one was more, it weighed more on me, and watching the documentary, it opened my eyes to a lot of things, because I know, like they were talking about the Pitocin, I have never been induced, but I do know with both of my sons, they were trying to schedule me for C-sections. And I would tell them, I said, no, I don't, that's something I don't want. I never wanted it, not unless it was something that they really had to do, if I wasn't able to do it. But they felt as though that was something that they were going to actually have to do. And I thankfully went into labor on my own. And then it was, sort of kind of the treatment that I got with my second son. It made me tell them, like, I don't want to be here. Send me home, because I felt like the treatment I was getting, they weren't listening to me. When I got my epidural with my second son, I wasn't able to feel on my left side. It didn't wear off completely, and I needed help going to the bathroom. And I kept telling them, I was like, hey, I gotta go to the bathroom, I gotta go to the bathroom, I gotta go to the bathroom. No one came. So this documentary have shed a lot of light on me, to me, and it's just making me like think of how can I be a part of the change? How can I help? How can I just basically, what resources can I give to, like, my sister? She's having a baby, and this will be her third child. Her second child, she had a C-section. Like, what, how can I help her? It's this has opened my eyes to a lot of things, and I'm just so thankful that this documentary has come out, because thinking that I wouldn't be here if sorry, those are my children. Thinking that something could have happened to me during my labor is very emotional to me. I can't think to not be here without my children. But this, like I said, this documentary has made me think of how can I be a part of the change? What resources what resources are there to where I can help, so that's all I had to say. Thank you.
Okay, thank you, Jessica, for that. Appreciate your comments. Vera? Vera, you might be muted still. I'm going to try to unmute you. You want to try again? I think we heard you, Vera. Okay, I think we lost Vera. No, still there.
Can you hear me?
I hear you. Yes.
Hi, I'm Vera. I'm a medical student, so I haven't dived into the medical field per se, but due to school, I've learned a lot about the injustices of just being Black in a medical setting. And I just want to share past experience of mine and a few thoughts I had throughout the whole conversation we've been having. So I was 18. I was put into the hospital I was admitted in because I had inflamed intestines. So I couldn't walk. I was doing a baby step. It was extremely painful. And I had asked for morphine. I was on morphine. I asked for it twice. I stayed there for about, I want to say 8 days, and I asked for morphine twice. The second time I asked for it, the nurse that came by, she told me that morphine is addicting and I shouldn't be asking for it. So it startled me because I'm in pain. I'm not asking for it because it feels good. I'm in pain and I just want release from that. So when she said that, throughout my next days, I didn't ask for it. I just laid in bed and I just stayed in my pain because I'm like, if you're treating me like I'm some type of drug addict, so I just stayed with the pain. And on the day of admission that I had to force, they kept telling me I had to stay longer and longer, even though they told me exactly what I had. I had intestine flames. My medicine was ready, but they wouldn't let me go. I had to tell them I want to leave. I want to go home. So the day to be discharged, they told me that, oh, I see you didn't ask for morphine. You must have not been in that much pain. And I was like, really? Okay, cool. So, and it's just like something clicked inside me. It was just like, y'all don't care that much. Y'all just don't care. And it's like, it's not to say it was, what made it worse that it wasn't even a racial experience, because I had Black and Hispanic and Asian nurses. It was a very diverse place. So I came to pinpoint on, it was that white doctor, it was that Black doctor. It was a whole diverse staff. And it just, I was like, okay. So with that experience, it triggered back when the movie that we watched, he said that she kept saying she had shortness of breath and they kept dismissing her. And my issue with that is, you don't know what the patient is going through. You can't measure pain. Pain should not be something that is measured. So if I'm saying I'm in pain or I can't breathe, I can't talk, that's a drop everything situation and let's evaluate what's going on. And especially documentation for the platelets. I know, I'm not even in the medical field. I know that if your platelets too low, I'm like, oh, you're dying. I immediately go to that drastic thought, like that shouldn't be happening to you. So the fact that there was 4 documents showing that there was a decrease, but no action towards it until she posted it. And that's another issue I like to bring up. We shouldn't have to put hospital or staff on blast to be heard or receive better treatment. It's ridiculous. Like, I literally tell myself, if I ever get sick, I need to have my phone on record, or I need somebody to, track me. So in case anything happens, there's my own documentation. And I shouldn't have to create my own documentation. And I shouldn't have to come to a hospital with a medical degree. Like, I need to know exactly what they're giving me and stuff like that. There's no blind trust. And I can also argue you should have a level of understanding at a hospital, what they're giving you and something like that. But at the same time, I shouldn't try to know more than the people that are responsible for me because I'm in fear that you may not treat me right. And it was just eye-opening, and it's upsetting because I believe awareness is important. I support awareness, but since I've been taking my class since January, so it has focused a lot on the injustices of Black people in the medical field, whether it be patient or staff members. So I'm tired of just hearing so many stories, and I need action. I need action. Like, yes, we're doing awareness, but are we passing a bill? And if there's a bill already passed, are we advocating for that bill to be in full effect? Like, we as a country worry about too many unimportant things, or things that can be put on hold, because the rate is getting higher each year. It's not getting lower despite all the awareness that's happening. So I just wish that as much as I do appreciate this awareness, I hope that eventually and very soon that we get more action than us advocating for ourselves.
Vera, I can't agree with you more. And we definitely have resources of organizations that are taking action to make sure that there are changes in the healthcare payment models, that there's changes in things for incentives for providers, that there are changes in tracking equity and measuring and trying to work to provide improvements in these areas. And so we can definitely help. And Jessica, same to you, to your point that you want to become more actively involved in affecting the change. We're here to support that, and we'd love to help you guys through learning what you need, exploring more resources that are available to you. Thanks, Vera. We're going to move to Dr. Walker and then Tiffany and Tanya. And then I'm just going to say we've got about 6 minutes left until the top of the hour. I apologize to ask you to keep your comments a little bit brief so that we can fit you all in. But I don't mind going a little bit over, but I think just out of respect for everybody's time, we'll probably try to cut it close. Dr. Walker.
Three quick things. The first one is for Dr. Fountain. Dr. Fountain, in 1979, I did postgraduate training at Henry Ford Hospital and started the first teen pregnancy program in Detroit. I don't know if it still continues, but if there's a program in the city of Detroit.
And that was you. Okay.
Awesome. That was me. The problem was recognized even back then. Right. Issue number 2, or subject number 2, going back to the film, what I try to do most often is find out in this elephant that's in the room, what is the common denominator, the small bite that we can take in order to consume this elephant. And the common theme that I see everywhere in healthcare comes down to a small thing. And most often it's about the small things. Now, implicit bias may not seem like it's a small thing, but if you take implicit bias and look at the complexity of a healthcare system or what goes into care of a patient, what happened and what you saw in that film and what we've all said is about implicit bias. Right. Implicit bias was the force, was the attitude that caused every single one of these situations, because people have this implicit bias that's not dealt with in nursing school, in medical school, and it can be dealt with on an individual basis, which means that you do not have to consume the entire pie in order to try to solve the problem. You can solve it by doing attentive listening and teaching that to every individual healthcare professional. The third thing I wanted to say is that as providers, individual providers, we cannot turn away from the impact that we have on whatever organization that we're in. For example, when I was practicing, when I had a situation or a circumstance in the operating room or in the delivery room where I had ordered a piece of equipment or something and it wasn't there, I enjoyed doing this, especially when it was 3 o'clock in the morning. If I didn't have that piece of equipment, I had the head nurse of that shift call whatever administrator was on call and tell them they needed to come into the operating room right now to see what me and the patient were experiencing because of their lack of attention to us. The clinicians, we have power to make these kind of changes. We've got to use that power to make the change. We can shout at administrators because we are the controlling factor within the system. Shout out at them if you don't have it. Tell them to come in when there's an emergency and things are going crappy, and make them stand there with you so that they can see what the outcome in the situations and circumstances are. Thank you.
Thanks, Dr. Walker. I couldn't help but wave at Matilda's helper. So glad to see you here helping us out with the conversation. Tiffany, let's jump to you. And then Tanya.
Really quickly, I want to kind of piggyback off of what you just said, because I do make sure I am a professor. I teach health science students. So they're all going into health professions. And one of the things I make them all do is they have to complete the HHS Culturally Competent certificate. That's allowed for undergraduate students. And the other thing that I do is I focus on empathy, because really it's an empathy issue more than anything. I think from the beginning, Black people weren't human. And I don't know that that has changed in the eyes of the greater society. And so when people aren't human, it's easy to treat them any kind of way. And that's kind of ingrained. And I don't know if that's, a component of epigenetics and some other factors, right? Some structural things, but it's ingrained that Black people are subhuman. And so one of the things that I try to do is help people to understand, we're all humans and we have feelings, and it doesn't matter your socioeconomic status. And far too often, people blame your race on your socioeconomic status. So it's just a great deal of ignorance, I think, across the board, and particularly in people who are in healthcare. When I watched the video, I was like shocked. All the healthcare professionals, by and large, were white, have a completely different understanding of society. And I'm pretty sure they were raised knowing that Black people are of a different tier. Society tells you that even if it wasn't overtly stated. You could walk in any neighborhood, in a Black neighborhood, and then go to a white neighborhood. It's kind of obvious that things are different. And so, we allow that to go forward. So to me, it's something that needs to happen really on a K through 12 situation, because I think once you get into medical school, I think people's minds are set, and they just see people in a different way. And I think a lot of the training, it might touch a few hearts, but the empathy has already left the building. And so one of the things that I'm doing is I'm working on a book called Black Health, the Open Conspiracy, because it's not rocket science, but we treat it as if the outcomes are rocket science. By and large, last thing I'm going to say is Black people have always been a commodity, right? And so until there is money involved in treating them appropriately, because typically money is involved when you don't have to treat them well, I think that's the only thing that's going to change. And because of outcome being associated with payments, I think we might get a little traction. But again, that comes back to policy.
Thanks, Tiffany. Look forward to reading your book.
Thank you.
Appreciate the comments. Okay, we are going to wrap it up with Tanya. I think as long as I didn't miss anybody else. So Tanya, we'll go ahead and let you have the last comment.
All right, thank you. I've actually put part of my comment in the chat, and that was in regards to the UC Health students. They actually pair them up with nonprofits so that they can have that experiential guided, even because they work closely with the nonprofit staff members. They work with the community members. They work with the people who are served by those nonprofits, and they create a study. They have a budget for it, and it benefits everybody. Not that all training can change all hearts, but it's something that is intentional, and I respect it, and it's been beautiful working with the students. I am a social worker, though I'm not a medical worker, and what I'm seeing is I kind of guess I'm looking for some insight on how to raise awareness, especially to those who are expecting, without creating panic. Speaking about the details of it makes it important, but it also upsets you. And if you're pregnant and they're like, I just came here for a crib. I didn't come here for all that. And so it becomes difficult for me to know how to speak to our neighbors in a way that even lets them know they can advocate for themselves. Because a lot of them is like, choice? I didn't know I even had a choice. So if anybody could speak to that.
Anybody who has a response, I'll just go ahead and jump in and share your comment for Tanya.
Well, I will say that we have been very involved with the Centering Pregnancy Program. And in communities where they've been able to do this and have a very diverse population as part of the Centering Pregnancy and working with the community, we have seen major differences in birth outcomes for both the mom and the baby. The clinical care, as those who are familiar with centering, is not changed, other than I do think they do a better job of getting the mom involved in their care from early on. What's changing is creating a social support environment. Those programs typically have social workers, may have community health workers, others, and when you make it more community based, where those women have an opportunity to not only interact with a broader team of professionals, but also interact with others that are pregnant and maybe facing some of the same challenges. Sometimes just a sense of isolation and the feeling that I'm the only one's going through this. Sometimes we've seen that it helps to have that ability to have a family support system that they may not already have, matched with a clinical team that is, to be honest with you, is more than just an obstetrician. It's usually going to be doulas, social workers, behavioral health specialists. So that centering type model, if done the right way and connecting to a broader team, I think can make a real difference.
Right, and I'll just jump in real quickly. So, Tanya, you being a social worker is very important. So, social workers, it's just like Dr. Foster said, doulas, and we actually just passed legislation here in Michigan where doulas are now getting paid, so they can actually get paid for the amazing work that they do. So, I think that that's a couple of responses.
And then I just wanted to throw my comments in. Every person in this country ought to have a healthcare provider, either a physician or nurse practitioner or PA, somebody that you have established a relationship with. I actually took care of a lady who I delivered 30 years ago, her son, and her son is now my patient, and I took care of her this morning. So it's that relationship. And it's the trust that's developed. Mm-hmm. So when I don't deliver anymore, and my patients go to the OB doctor for the delivery, but the baby and everybody comes back, we stay together. Now I do plan on retiring one day, so we need our medical students on here, okay? But the point is establish a relationship with a healthcare provider and get that trusting. Use that trust so that they can advocate for you as the individual.
Yeah. Jessica, I see you have your hand up for a comment too. Go ahead and jump in.
I just wanted to jump in and say, I understand what you're saying about getting a healthcare provider that you trust. I am a recipient of Medicaid, and it is hard to find a provider that you can trust. I will give an example. I took my children for a checkup, and most of the time I have been on time. I've never been late. And before my last appointment, they have seen me right away. And this last appointment, and it fired me up really bad, because this last appointment I had sat in the doctor's office for like an hour. And I asked the lady, I said, well, why is everybody going before us? And, we were here on time. And she says to me, oh, it's because of the insurance that you have. Wow. And I said, wow, to me, it's not just, and I trust my provider, me and her. She's dealt with me with my first son, my second son. She's a great provider for my children. But based on that statement alone made me say, I don't even want to come back here. Now I have to find a new provider for my children because of the way that you treat me, because of the insurance that I have. Mm-hmm. You see what I'm saying? So I understand what you're saying, but it's hard to trust the providers, OBG, whoever, when your care is based on your insurance.
Yeah. Jessica, that's a horrible experience that you've run into. I'm really disappointed to hear that. We'll have to, maybe you can give us all their phone number and we'll call them and we can all chew them out.
You need to put that practitioner in the car with you, and y'all need to drive to another practice because he or she needs to be in a different practice as well. She probably doesn't realize that she's trying to do the right thing, and she's in a system that doesn't understand the right thing to do.
Yeah, you've got a front desk.
Private equity now owns the healthcare system, so it's a challenge.
It's true, Tiffany. There are a lot of challenges, and I mentioned this before. Eric and I, we work for the Institute for Advancing Health Value, and the purpose of health value is to achieve equity. Value-based care, if you've heard that term, or value or outcomes, or the things that are changing in the system, where we have payment models and policy changes that are happening, it's all supposed to lead to equity. And if people aren't looking at it like that as a means to an end, they're approaching it the wrong way. We're really hopeful, and we have a very positive outlook on where the system is moving. There are a lot of good people with a lot of good intentions, and a lot of organizations making investments and trying to change how they're delivering care. We've got a podcast that talks to lots of these people once a week. In fact, this week we talked to Dr. Neil Shah from the documentary. We've got an hour-long conversation with him that's just incredible insights that go in depth on a lot more of the things that he kind of scratched the surface on in the documentary. So we invite you to listen to that. Invite you to join, again, free membership for provider organizations, and so if you have any questions, Ashley's on the call, or she has been, and you can reach out to Ashley or Shemaine on our team, and we can assist you. We'd love to help follow up and help you guys continue to be advocates and add your voices to this really important movement. So thank you guys, everybody. We're really appreciative of you and your contributions and your time.
Thank you.
Thank you.
Thanks so much, everybody. Have a wonderful evening.
You too. Thank you.
See ya.